So this is truly an exciting panel and some really magical stuff I'm going to talk about on improving pain after surgery with less narcotics. But first, I'd like to introduce the panel. We have Dr. Ehsan Jazini. He's our spine surgeon, and he's editor of the Foundation's Journal. Next to him is Ashley Malliarakis. She is our beloved registered nurse at Reston Hospital, and she's also a spine navigator there. Ashley, can you tell us a little bit about what that means?
So my role basically is to be really involved after the care. They kind of see my face in the beginning with a little orientation video. I try and reach out about a week before patients' surgery and kind of give them a rundown of what to expect while they're in the hospital. This is a super anxious time in their lives, a big, big surgery. So if I could take out just this much of the anxiety of, what does my nurse look like versus a nurse tech? What is a nurse tech? What are these drains that are going to be on me? Are there going to be drains? Just little things about how their recovery is going to start, and it starts in the hospital. So I come and I see the patients every day. I try my best to be there when the surgeons are rounding or the PAs. And basically, we're on a touch basis all day long via text or via phone calls on fine-tuning the patient's care. So anything that needs to happen with the patients, even acute changes, I'm able to report back to them, and they can respond immediately, even while they're in clinic. So.
And let me tell you, this is crucial. I did not have her there with me this morning, and it took me, twice as long to do all of my work, so we appreciate it. So, we've talked a lot about surgical techniques and how there have been great advancements over the past decade in spine. Minimally invasive surgeries, smaller incisions, navigation systems, robotic guidance, 3D printed implants. I mean, you name it, we've got it. Spine is blessed with all these technologies. So it only makes sense that we have rethought the way we recover our patients. And traditionally, we were using IV pain medications, and these can be very strong and have lots of side effects. They did work at controlling pain. They mask pain. They make you sedated. They make you very constipated, sometimes very confused, and even nauseous. So the recoveries were very slow with this pain technique. But if you start to think about the different pathways of pain and how you treat these pathways, you can use various types of medications instead of narcotics or opioids or painkillers, and really control pain in a much better way with less side effects. So what we're doing is when our patients come into the hospital the day of their surgery, we're giving them a cocktail of medications. And this is before they go back to the operating room. They're completely awake. We give them an anti-inflammatory agent. We give them a muscle relaxer. We give them a nerve medicine, a long-acting pain pill, and high-dose acetaminophen. Now, some people will say, oh, that doesn't work for me, acetaminophen, that's too mild. But we give it at a high dose, and in the hospital, this is extremely effective. So as they say, don't knock it till you try it. It really does work. So the patients take that cocktail, they go back to the operating room, and during surgery, we're working very closely with the anesthesia teams to calculate the maximum dose each patient can get of a numbing agent. And we're injecting that in and around the surgical area so that when you wake up from surgery, you're actually just numb there, and that's better than pain. And that numbness can last for hours. So when we wake up, we have less pain, and we're awake and can swallow pills. Again, we don't need those IV drugs anymore. If you're too sedated and you can't swallow the pills, you get the IV and you're more sedated, and it's this vicious cycle. So our patients are waking up in the recovery room, they have better pain control, they're awake, and they get taken to the surgical floor. Ashley, if they're awake and alert and their pain's controlled, what can they do when they get to the floor?
They can walk. There's this little thing, it was like the best kept secret as to the key to recovery, and it's mobility. People had underestimated that, I think, for quite some time. We just didn't know, this old wives' tale of rest is everything. So, we were putting the patients in the bed, giving them this lovely button, and they were just out of it. They weren't going to the bathroom. They weren't really able to mobilize yet. They were out of pain. They were recovering, but at a much slower rate. Now we're able to get them on their feet just hours after surgery has started.
So once we mobilize them faster, they have restoration of their normal functions. Their GI systems wake up faster, their urinary systems, and truthfully, everyone wants to know, when can I go home? The minute you check into the hospital, the first thing you think of is, all right, when can I go home? I need my bed. I hate this hospital bed. And we're getting our patients home faster, and they're recovering better when they get home. And so this is truly exciting, and we're very happy to talk about it. Dr. Jazini, we need to tell the world about this awesome technique. Our patients are recovering fast, but we need to spread the word. How are we doing that?
So first of all, we wanted to see how are we doing. We wanted to measure the success of this program. Anecdotally, my experience with this program has been very good with my own patients. But we really need to measure that to understand how we can better tailor this program for each individual patient. As Dr. Schuler mentioned earlier, every patient is different, every surgery is different. So we really need to understand what we need to do for each individual patient and really tailor this program. So for the past 2 years, we have been studying how patients are doing with this program at our center and also other centers that we are collaborating with to really understand how we're doing. Are we really getting patients faster, home faster? Are they really taking less painkillers? How are they doing after surgery or over the 3 months when they're recovering? Are they really doing better? And so far, the results have been a resounding yes to all those questions. And in fact, we are presenting these findings at a national meeting in September so we can share this finding with other specialists around the country. And now the next step is to really understand how we can do multi-centered studies so that we can better tailor this program. The patients are different. Someone has scoliosis is going to have a much bigger surgery than someone who's only having a one-level procedure. So we really need to tailor this. I think there's a lot more work to do, but the results are very promising, and I think it's very important by empowering patients around the country through this kind of panel so they have the knowledge to then go and seek more information about this.
Yeah, that's the key. We have to tell you what's out there so you know what questions to ask. Actually, the hospital is also tracking the data. You're looking very closely at it.
Definitely.
Are you seeing the same results?
It's actually been remarkable. I think we were all blown away simultaneously by what is changing with these patients. So that's also a part of what I do is I track all the patients' functions. So from mobility, when they're mobilizing, if they're mobilizing that very same day or if it's the next day, and for what reasons, what kind of pain regimen they're on. It was a big push in the beginning to try and have this beautiful multimodal pain regimen with all those different oral medications that cocktail that we give preoperatively is then continued on the floor. So gradually we just saw the IV medications dissipate. We realized that we don't need those big, heavy knockout narcotics because the patients are waking up in less pain. So they've got control at the front end, so you're maintaining that throughout their entire process of recovery in the beginning.
We were told that there was a lot of buzz already about this topic, and I'm getting some clues that we have some questions from audience members. Let's take those questions. Excellent. So the first question, actually these are from around the nation. These have come in from around the nation. So our first question is from Betsy from Idaho. Hi, Betsy. Thanks for tuning in. Betsy says, I've been told I need a back surgery to help my leg pain. I'm excited to hear that patients can get up and walk after surgery. How soon do you see patients walking with this recovery process? So,
like I said, it's about hours after surgery. Once the patient is taken to the recovery room and they're recovered, the PACU nurse, which is the post-anesthesia recovery unit, that nurse brings the patient up, parks the stretcher in front of their assigned room. The physical therapist is awaiting them. So the physical therapist does strength tests, evaluates their cognitive ability, and then deems if they're safe or not, gets them onto the edge of the bed. We wrap a gait belt. It's kind of like a belt. It's just kind of a canvas soft material. So we put that around their upper extremity as far away from the incision as possible. We use a walker and we slide a hand under each side. So with physical therapy and the floor nurse, we stand the patient up right there and they do their little walk right into the bed, into the room. It's honestly a remarkable moment for a lot of family members that are seeing their family walk for the very first time. Lots of tears, yeah.
Well, I think Betsy's going to be excited to hear that. Our next question's coming in from George from Montana. George says, I had a spinal fusion a few years ago and had quite a bit of back pain after surgery. I had a pain button while I was in the hospital and find it hard to believe pain can be controlled without it. Can you explain how this works?
Sure. So the idea behind the pain control button was that patients can control their pain better if you gave them the control to do that. The problem with the pain button was that patients would then fall asleep and then wake up in pain. So the idea behind this program is that we can tailor how much pain medications they actually need, and by combining both short-acting, which means more immediate pain control, as well as medication that stays there in a more longer-acting way, patients' pain is actually better controlled for the longer duration of their stay, and they're controlled at a steady rate so that they don't have these highs and lows. And by doing that, we're able to really better control patients' pain and get rid of another source of narcotic that really is not allowing them to really do what they need to do to get back to their lives faster and get out of the hospital sooner.
It's true, George. We got this down. The next question's coming from Jackie. She's local here in Richmond, Virginia. Hey, Jackie. She says, I'm a chronic pain patient, already taking a few different types of these medications you're talking about. Do you adjust your recovery techniques for chronic pain patients?
So like Dr. Jazini was saying, we actually have kind of two set tiers for now. We have one that's for opioid naive, which means you hardly ever take a narcotic, and then opiate tolerant, which means you've been on these medications for years. So even we have a kind of a standard that we go off of, and we dial up or dial down depending on the needs of the patient. So if they're having too much pain or if they're too sedated, we go up, we go down. And that's kind of the beauty of this whole thing, is that it's individualized. Each patient has their own regimen so that they have the most supreme pain control.
Excellent. Next is Mark from West Virginia, also maybe nearby. Mark says, with growing concern for the opioid crisis in America, he's on the same page with Dr. Schuler, in addition to knowing a few people who have gotten hooked on pain pills, I'm terrified to take pain medications myself. Are you seeing less addiction after patients are recovering from surgery?
Mark, that's a very great question. I mean, I get this question from patients who are concerned about this all the time in my office. And what we're doing, from societal aspect, from the government, from hospitals, from surgeons, everyone's trying to tackle this opioid crisis. And programs like the one we're just talking about today, as well as by doing surgery more in a minimally invasive fashion, we are able to control patients' pain better, get them back to their lives faster, and to really decrease the exposure to these painkillers. The misconception here is that patients' pain are not going to be controlled. The whole idea behind this is to really better control their pain and really better get patients back to their lives so that the risk of addiction and abuse is decreased. So that's a great question.
Excellent. This next one comes from Kelly from Pennsylvania. Kelly says, I could not wait to get home after my back surgery last year. She probably wanted to get in her own bed, I'm sure. Do you find that your patients are going home faster with these newer techniques?
Absolutely. That's been my most favorite part of tracking all these trends and data, is actually seeing the days kind of dissipate off people's stay in the hospital. Another thing that was kind of surprising to us, we're checking off those boxes earlier. Now that we're walking the day of surgery, the next day patients' catheters are coming out, so they're able to void sooner in the bathroom. Their pain they're already on an oral regimen that they can now take at home. And now physical therapy is deeming them already safe because they've already taken 6 laps in the hallway, even by the next morning comes around. So what was actually a 4, 5, 6 day stay is now becoming 2 and 3 days long. So on average, we've actually knocked off a day and a half on length of stay. So you can actually enjoy your bed a lot sooner.
Get back to that bed.
I'd like to chime in as well. From a personal experience, my brother had scoliosis surgery 20 years ago, and it took a month for him to recover. He was in the hospital for a month.
Wow.
And for the same type of surgery, patients are leaving 3 days after surgery. Every patient's different, but it's amazing the tremendous leaps that we've made in spine surgery over the past 20 years. And programs like this, it's not just a technique, it's the technology, but also these other programs, the nurses, the PAs, everyone around the team, the hospital, to really get patients in the right direction.
Definitely.
Yeah, we're dedicated to demonstrating treatments that work. And if you're having a spine surgery and you're not local, ask your team, do you use IV medicines after surgery? We talk to each other about this enhanced recovery after surgery, and we call it ERAS. Ask them, do you know what ERAS is? And hopefully the answer is yes. Dr. Schuler?